Dr. Reyes,
Hello.
you're muted.
Oh, yeah, thanks.
Okay. Hello, everyone. My name is Annie Benzie. I'm the chair of the fellow subcommittee for SSAT, and I am very delighted that we have another bariatric talk for this month. And special thanks to Dr. Altieri for graciously joining us this evening. She is assistant professor of clinical surgery at Penn Medicine, as well as the section chief of GI surgery at Pennsylvania Hospital. We are having a presentation on one of the many topics that she has published and written on. So if you wouldn't mind taking the lead, Dr. Altieri, you can kick us off for tonight.
Well, thank you so much for that kind introduction, Dr. Benzie, and thank you to the SSAT for having me today, and also thank you to Dr. Reyes, who is an advanced GI fellow at Banner Gateway Medical Center, and who will be presenting on anastomotic complications following bariatric surgery and their management. I feel like that's such a broad and like an excellent topic, just because we do have a lot of bariatric surgery that is being performed in the United States and around the world. And so even if you don't choose bariatric surgery as your field and you go in practice somewhere that sometimes you take like bariatric or even just general surgical, these patients will end up in an emergent setting, and sometimes you might have to take care of them. And it's so important to have at least a baseline knowledge of some of the complications, some of the risks, some of the technical aspects. So I'm very excited to be able to moderate this session. So thanks again, Dr. Benzie, for that. And Dr. Reyes, yes, the floor is yours.
All right, thanks, Dr. Altieri, for the discussion, and to the SSAT. Dr. Podkamini is also my attending for NPD for this program. But again, I'm the Advanced GI Surgery Fellow at Banner Gateway Medical Center. We'll be discussing the broad discussion of anastomotic complications following bariatric surgery. Of course, no disclosures, and just very brief overview. Morbid obesity is a world pandemic with its implication to other comorbidities as well, and its significant cost to patients, society, and healthcare. Management is multidisciplinary, with surgery being one of the most effective and durable methods for weight loss, as well as control of related comorbidities when applied correctly. Fortunately, as experience and technologies evolve, the overall percentage of postoperative complications is decreasing, but with its increased utilization, the absolute number of patients that we eventually see will still increase. So there are a number of bariatric surgical procedures that have been implemented here in the United States as well as worldwide. But I'll be primarily focusing on sleeve gastrectomy as well as Roux-en-Y gastric bypass, since these represent the most common procedures utilized here today. But in general, several of these involved either a gastric staple line, and in the bypass procedures include gastroenteric or duodenoenteric anastomosis, either in a Roux-en-Y or loop fashion. So understanding at least the basic postoperative anatomy is vital for identifying and managing postoperative complications. At least in regards to anastomotic complications, these exist essentially anywhere a staple line or anastomosis exists. And broadly, these include marginal ulcers, strictures, obstruction, bleeding, leak, and fistulas. Workup for these patients or patients that present with a history of bariatric surgery, either to the ED or even the clinic, with problems such as abdominal pain, nausea, or dysphagia, typically starts with a thorough history and physical exam to evaluate for patient stability or the need for more urgent interventions. Some signs that might push towards more urgent interventions might be tachycardia, especially over 120 beats per minute, fever, signs of peritonitis. And also it includes a thorough examination of the medical record for prior postoperative reports or operative reports, or imaging that might assist with understanding their postoperative anatomy. For patients that are stable enough, that don't need emergent presentation to the OR, CT imaging of the abdomen and pelvis with IV contrast, and ideally PO contrast if the risk for aspiration is minimal, can be really valuable for these patients. And additionally, CT angiogram of the chest sometimes might also be helpful to perform simultaneously, as some of those symptoms for venous thromboembolism can also overlap.
And so if you just stop there for, so Dr. Reyes, if you're concerned something like a leak or more proximal, what is one way that you can do like an upper GI with a CAT scan? You know what I'm kind of going forward towards?
For an with oral contrast, like a bariatric protocol CT scan.
Yeah, so you ask, usually you tell, because like not every ER knows this, or radiology, you ask them just to do like on-table contrast to just kind of evaluate that area, like depending on where you think that it might be, like no, for some of the patients you're not going to know. But if you're like concerned about like a leak, you ask them to do an on-table contrast, to drink some contrast on the table, and then just kind of evaluate that. If you're concerned for something more like an internal hernia, like that's not the way to go. But like almost if you don't have an upper GI series.
Yep. Thank you. So for patients presenting more acutely, the general management includes fluid resuscitation, as well as IV vitamin supplementation for at-risk patients, broad spectrum antibiotics or PPIs when indicated, as well as source control and consideration for nutritional supplementation or nutritional support. The first case I'm going to be discussing is of an 82-year-old female with a history of hypertension, coronary artery disease, stage 3 kidney disease, and Parkinson's disease. She had a remote history of a Roux-en-Y gastric bypass at an outside facility over 10 years ago, wasn't taking any PPIs ever, and was taking meloxicam chronically for back pain. And she presented with a one-day history of abdominal pain, found to have a moderate amount of pneumoperitoneum on CT scan. Just for the group, if anyone had any ideas of how they would manage this patient, I'd love to hear the discussion.
So what are you guys gonna do? What are your thoughts? What are your concerns? Can I call him?
Sure. Dr. Mai, do you want to weigh in since you're our other bariatrics fellow on this call?
Yeah, sure. So, depending on, at this point, I'm thinking about a perforated, probably marginal ulcer with the patient's history of a gastric bypass 13 years ago. Depending on how she's doing clinically and her hemodynamic stability, if there's a moderate amount of pneumoperitoneum, she may need to go to the operating room, or this is someone that we can do more of a clinical approach and observation and maybe endoscopic approach, conservative management. So just depends on how she's really doing clinically in her abdominal exam.
Thank you. So for this patient, vitals wise and labs wise, she did not have any signs of severe sepsis. Her vitals were normal. Heart rate was in the 80s, it was not febrile. And as far as white count and labs goes, there was essentially nothing notable. Her white count was 7. She did have clinical signs of peritonitis. So we opted for operative management for this patient, and we took the patient to the OR for a diagnostic laparoscopy. And eventually we did see near complete anastomotic disruption secondary to what you had mentioned, Dr. Maya, perforated marginal ulcer. Would anyone like to kind of explain what they might consider doing for this patient with near complete anastomotic disruption?
Dr. McDowell, any ideas?
Bariatrics definitely not my forte, but I think if you have like almost a complete disruption in the anastomosis, if they have a sizable enough pouch, you might have to redo the whole anastomosis.
Yep, so that's what we did for this case. We redid the anastomosis. I didn't mention, but this patient was also kind of more on the malnourished side, despite having a history of morbid obesity, or BMI was like 18. So we opted for also placement of a remnant gastrostomy tube for nutritional support postoperatively. But we did revise the anastomosis. Because of her comorbidities, we did convert to an open procedure for this case, just to expedite lysis of adhesions as well as revision to minimize time on table.
Can I ask you something? So if somebody, like when you go into marginal ulcers, pneumoperitoneum, et cetera, like you're always kind of asking the questions, right? One of them is like, what are some of the risk factors for marginal ulcers?
What are the risks? Risk factors for marginal ulcers, tobacco use, NSAIDs. I'm going to go into a list of that shortly in my next couple of slides. And just do that.
So patient selection is very important in that aspect, just because even from beforehand, like you have to make sure that somebody doesn't have to be in chronic serious or NSAIDs, or they're a smoker and have like a chance of actually they quit, but it's probably most likely they're going to come back to smoking as well. And then something else that, you know, like you always kind of assume that it's the marginal ulcerations, but I've had a couple of patients now that have had a remnant ulcer that has perforated as well, and a dual ulcer as well. Just, you know, like never, like if you go into like evaluate the pouch and the GJ and you don't see anything there, like start looking around more into those areas to see if that's something that can also be present. I've been surprised.
All right, thank you. So regarding marginal ulcers, these are typically peptic ulcers at the GJ anastomosis due to a number of different factors, but some of them being lack of buffering ability of the jejunum and inflammatory microvascular alterations after surgery. These can contribute to tissue or mucosal breakdown and ulceration. These can present months to years following Roux-en-Y gastric bypass, diagnosed endoscopically. It can also be asymptomatic, but some, like in this case, can result in perforation. Due to the anatomical basis of how these develop, the risk is essentially lifelong following a Roux-en-Y gastric bypass. So something to keep in the back of your mind for patients who have had a history of bypass. So risk factors, NSAIDs, tobacco use, poorly controlled diabetes. As far as mechanical things, having a large pouch that can contribute to acid secretion, development of gastric fistulas. Interestingly, circular staple anastomoses is also a risk factor for marginal ulceration, and any contributing factors to ischemia or anastomotic tension.
I just have a quick question. So I remember, I don't do bariatric surgery, so caveat to that, primary bariatrics. But is there an age cutoff? Because this lady was 70 when she had her bypass. And way back in the day, I always remember learning like 60, 65 being for a bypass patient. So I was just wondering if that is still common practice. Because like you said, everyone over a certain age tends to have osteoarthritis and they are all on meloxicam. So just wondering.
Specifically, Dr. Benzi, I don't have an age cutoff. As long as patient is a reasonable candidate, especially with the data now that it shows that bariatric surgery actually improves morbidity and mortality, and so like it can prolong a pretty good lifestyle in terms of like a healthy lifestyle and life. I would offer that to my patients. If they have any contraindication, there's always, you know, like now there's newer medications that they can use, etc. But if they're a good bariatric candidate, I would offer them bariatric surgery. I don't know about anybody else that has.
Can I jump in? I'm Dr. Podkameni. I'm his program director. I was keeping quiet here, letting him present, but it's very important that we don't put a cutoff limit on those patients, because some will behave like someone with 65 or 60 years old, and some will behave as 60, but they are 75. So risk, I think it pertains more to how we're going to assess the patient more than a cutoff number in terms of age. Having a background in pediatric surgery, we go in our program from 16, 15 to whatever age you name it. I think it's the risk assessment that's going to give us a real picture of how to proceed.
Can I go against the grain here?
Please do.
I tend to have my cutoffs around 65, 70. There's a published paper from the ASMBS last year that looked at overall complication when it pertained to gastric bypass, and it shows a threefold increase in complication for population above 65. So this was pretty recent. This was just published last year. Personally, like I look at the patient, but 65, 70, depending on their functionality and how good they look. Also the knee. I mean, if someone have Barrett's, sure, you know, it makes sense to do someone higher than 65. But if someone is 65 and they're looking for weight loss purposes, I don't tend to do it for people over 65.
Yeah, we don't put a specific cutoff, and you know, remember when we read a paper, we're ending up being biased to the how they selected those patient populations. So we have to be really careful in terms of our selection. I agree with that. Absolutely, after 65, there are other considerations, and if you can do possibly a sleeve or even medical management if the patient is not in good health conditions, yeah, absolutely. But I think we also need to understand that all those papers and everything that is published is to give us guidelines for us to, you know, develop our best practice. And sometimes some individuals will be eligible for a gastric bypass versus a sleeve or versus medical management. So it's just to take into consideration and not be so dogmatic about, oh, if you are 65, that's it, you're done. But it's possible that someone at 60 is not totally eligible for a gastric bypass and needs something else done.
Perfect. So Dr. Reyes, you have 2 questions in the chat, and this might be a little. Is there a role for H. pylori radiation therapy, and when would you consider reversing the bypass in an emergency operation for marginal ulcer perforation?
I think there is a role for H. pylori eradication. I think from what I was reading, there wasn't like a really direct connection with H. pylori with marginal ulceration, but it does predispose you to developing those ulcers. As far as reversal of gastric bypass in an emergency surgery for marginal ulcers, I don't think I would do that because they're already at risk of anastomotic complications. So I wouldn't do that emergently in a perforated episode.
And Dr. Hassan has his hand up. Sorry.
All right. Sorry. So again, just for full disclosure, I'm a colorectal surgeon, but I take general surgery call. So we do get these patients. So from a system standpoint, who should fix these? Should this go to general? Do you think general surgeons should be able to fix these kind of problems, or will the bariatric service come and fix it? Or it depends upon the time of the day also. So that's one call in general. And then the other thing is, when would you do a gram patch? I know this was a complete disruption, so there are 2 parts of the question, but what if there's just a 5 millimeter hole? Would you just treat it like a perf DU and put a patch on it, or would you just like over sew it? So from a technical standpoint. And the third thing is there any role for putting a covered stent in, or ever a role for throwing in a covered stent and avoiding going in the abdomen? So 3-part question, sorry, thanks.
Let's see. First question was about who should fix these. I think general surgery is definitely capable to fix these. I mean, these are essentially general surgery cases like any other perforated ulcer, especially in the emergent setting. Of course, if bariatric surgery is available, that is one thing, but I think these can be treated just like any other perforation. For the smaller perforations, I think those can be treated I guess more conservatively with the gram patch, especially if it's in a delayed presentation with gram patch and source control, wide drainage, and whatnot. I think there was one more question, but I might have got lost.
Stent, can you throw in a covered stent in these patients? I mean, is there any evidence of, instead of making a laparotomy or a laparoscopy, endoscopically putting in a covered stent across the anastomosis?
I don't know the data as far as covered stents.
Let me help Dr. Reyes with that. No, we've never done, we've done in our service over the past 15, 17 years, possibly more than 2,000 gastric bypasses. And we've never faced a situation where we needed to use stents on a perforated marginal ulcer. So to answer, I wouldn't try. I wouldn't think about putting a stent at this point. I would try to fix the marginal ulcer or redo the anastomosis if need be. the other thing that we have to think is in terms of placing a stent is the complications and consequences of having a stent there, where erosion or even if the stent is appropriate to be placed beyond the gastrojejunal anastomosis, really. So the stents that we have, they're more geared towards either colonic surgery or the esophagus. Having said that, obviously we use stents in the stomach, but it's kind of controversial area to start placing stents on ulcers like that.
No, I
I'll be
agree.
afraid of especially erosions.
Sure. No, I agree. It seems conceptually a good idea, but I haven't
Mhm.
seen it done. So a lot of things may sound good, but may not be in reality that good. That's why I asked the question. Thanks for the
Yeah,
clarification.
and this is versus a perforated acute process versus a chronic leak. And I think Dr. Reyes is going to talk about that.
All right, Dr. Hassan, very nice to see you here. I just wanted to kind of chime in here, and Dr. Reyes covered the questions very well. Yes, like anybody, probably general surgery should be able to fix it, but if there's a bariatric surgeon, I think the way that a potentially laparoscopically trained bariatric surgeon can fix this versus a general surgeon might improve the outcomes in terms of like doing it laparoscopically versus open. And of course, even if there's no guarantee, even if it's one of us that we might not have to convert to open, but definitely if it's laparoscopically trained and we're able to do it, that's probably the better way to do it. In terms of the stents, I agree with Dr. Podkameni. We rarely use these. It's usually for sleeves and for leaks, but I've never had to place a stent for such an issue. This is also complete disruption of the staple line, so stent would not work here.
All right, thanks.
Right. Great. So thank you so much. So as far as just general management for perforated ulcers, like we kind of mentioned already, fluid resuscitation, antibiotics, source control with wide drainage, momental patch. Those are all for smaller perforations. Obviously, larger perforations might require revision. And then consideration for distal enteric feeding access is important. For non-perforated ulcers, these are typically just treated medically with PPIs, Carafate, as well as risk factor reduction. And for chronic or recurrent cases, sometimes these require revision, reversal, vagotomy, or even gastrectomy with EJ anastomosis in very extreme cases. For these recurrent cases, also consider Ehlers-Danlos syndrome. The next case I'm going to be discussing that we encountered in our group was a 76-year-old female with a history of hypothyroidism, history of Roux-en-Y gastric bypass at an outside facility 6 years prior, who was also not on PPI therapy, but presented instead with a 3-month history of progressive intolerance to solids and liquids. And again, question for the group, how would you all manage this patient?
Dr. Likes?
So something along that line with progressive intolerance, I'm assuming, your initial workup would be suspicious for something like a stricture at one of the anastomotic sites. And if all you really have is progressive intolerance, then I would start out by getting a good history and physical, and then imaging. You could do either, if you were concerned for stricture, you could do either a contrasted swallow study or CT scan.
Thanks. So this patient was worked up at another facility. They did get a CT scan. They also did a endoscopy that revealed a pinpoint stricture, and they didn't have bariatric surgery coverage at that other hospital since they're more of a rural facility. So they got transferred to us. So she did have a chronic stricture. We performed our own endoscopy, and following that, performed several multiple dilations kind of on a 1 to 2 week basis. But at our 4th session, there was concern for a perforation. How would any of you all proceed after that?
When they did the dilation, did they actually witness a perforation?
There wasn't like really obvious, like there wasn't like you could see inside the peritoneum, but there was concern for perforation based on how the mucosa looked at that point and some of the tissue below that. And then there was also a CT scan that followed that that showed a continuum.
And where was Dr. Reyes? I'm so sorry, maybe I missed this, but where was the stricture exactly?
It was at the GJ. It was a GJ anastomotic stricture.
Okay.
All right. So we kind of followed a similar approach for this patient. We performed a diagnostic laparoscopy. Fortunately, there wasn't as many adhesions for this patient. But given that she's had a stricture that was kind of refractory to balloon dilation, as well as that it was contained leak or contained perforation, I should say, not leak. And it was acutely presented at the endosuite within the hospital. We opted for revision of the GJ anastomosis. Following that, she did better.
I believe she had an ulcer too, right?
She did have an ulcer as well. Yep. So as far as anastomotic strictures, these have a wide range of incidence depending on what series, but 3 to 28%. More common in patients who have had circular staple anastomoses, as well as history of ulcers. These patients will present with dysphagia, nausea, emesis reflux, and progressive intolerance from solids to liquids. As far as the diagnostic definition, this can vary from center to center, I guess, but usually it is based endoscopically with the inability to pass a standard size endoscope, which is about 9 millimeters, requiring dilation for improvement of symptoms. As far as the pathogenesis of this is kind of a combination of ischemic and inflammatory, but it's like a process of tissue necrosis, delayed epithelialization resulting in fibrosis and ultimately stricture. Some contributing factors could be foreign body erosion with use of non-absorbable suture, ulcers, prior leaks, whatnot. So as far as risk factors, there's a lot of overlap with marginal ulceration, smoking, tissue ischemia, scar contraction, subclinical leak, history of revisional surgeries, acid hypersecretion, and then any kind of tension at the anastomosis. In regards to specifically for circular stapled anastomoses, there's been studies on 21 millimeters versus 25 millimeters where they saw a significant increase in incidence of strictures for the smaller circular stapled anastomoses for 21 millimeters, having a higher risk of strictures without any additional benefit for weight loss. As far as management, treatment for anastomotic strictures.
Can I give 2 cents on the etiology there that you're talking about?
Please.
Because it is important. I think sometimes we forget how gastric bypass is done by some of the surgeons, and they place a ring around the anastomosis, around the gastrojedge, and you have a silastic ring, a fixed silastic ring there. And that can be a point of stenosis there. So evaluating those patients, you have to find out in terms of their operative report. And if they don't have an operative report, a lot of times that ring can be seen on either an X-ray or on a CT scan. So it's just to be very careful and remember that you can have what some of us call a Phobie ring around the gastrojedge. And if you're going to dilate those patients, you're going to dilate against a fixed point. So the actual solution for that is to go in there and probably take the ring out in those cases.
Thank you.
Note there's like 2 standard type bypasses. One is, as David mentioned, is the Phobie pouch. The other one is the VBG bypass by Rafael Capella. Those could be seen and they're usually incorporated. So those are not removable.
I'm just going to interrupt you for a second because sometimes, yeah, we have to be very careful with the ring as well. Like you said, one can be silastic and it's something you can remove. The other one is a Marlex piece of band. It's sometimes possible to remove the Marlex, but we see more of the Marlex eroding into the GI tract. And normally when we see that erosion is not such a horrible thing because we're usually able to remove it endoscopically. So that ends up being not such a bad thing, I guess.
All right, thank you. So I guess outside from that situation with the band, for I guess just primary strictures, management for those are typically non-operative with dilation be able to manage for most strictures. But there's a small percentage of refractory cases that require operative revision, and also along with balloon dilation, risk of perforation and risk of bleeding, especially in the first 90 days due to neovascularization. All right, next case that we encountered was a 50-year-old female with a history of morbid obesity and hyperlipidemia and GERD. She had a sleeve gastrectomy, again at another facility 5 years prior to her presentation to us, who developed weight recurrence as well as worsening reflux requiring multiple antacid medications for just modest improvement of her symptoms. She ultimately went for a revision sleeve to Roux-en-Y gastric bypass for refractory reflux. But her case was complicated by anastomotic bleeding at the JJ anastomosis, resulting in SBO and an acute anastomotic leak from the resulting hemobesor. So just very briefly in terms of bowel obstructions in the bariatric surgical patient, specifically for post-op bypass patients, these can be due to a number of reasons, including stricture, bowel angulation during formation of the anastomoses, intraluminal hemobesors, like in this case, intussusception, especially at the JJ anastomosis, non-anastomotic causes that we talk about a lot are internal hernias, but also any of the other etiologies related to general surgery as well, like adhesive disease, abdominal wall hernias, or in a recent post-op patient, port site hernias, neoplasms, any of the possible causes of bowel obstruction. It's just a video of that patient's CT scan. You can see multiple loops of dilated small bowel, as well as a distally decompressed colon and distal small bowel. And you can also see hyperenhancement of fluid kind of near the JJ anastomosis. If anyone believes in Hounsfield units, that was about 90 versus the other fluid was about 9. So consistent with intraluminal bleeding. As far as SBOs for post-op bariatric patients, symptomatology is very similar. Main difference being that if, for example, there's a closed loop bowel obstruction where the BP limb is obstructed, this might not necessarily result in nausea and vomiting, and neither is the improvement with a nasogastric decompression.
So what would, like, if you have a BP limb obstruction, what is something that you can see, Dr. Reyes?
Yeah, so for BP limb obstruction, you can see dilated, well, you would see the dilated BP, but also a distended gastric remnant on CT scan as well, and possibly on plain film X-ray, but that's sometimes very difficult to notice.
I think she's referring lab-wise.
Yes, thank you.
Oh, lab-wise, I don't know the answer to that.
If you have an obstruction at the BP limb, what do you think it's going to happen with bile?
Oh, I see what you mean. Yeah. So you might see transaminitis or elevated T-bili with those due to bile reflux.
Like a really nice point just to kind of highlight, because a lot of people are like, oh yeah, there's something wrong with the gallbladder, and no, it's not. Yes.
Thank you. So for these patients, management kind of mirrors the same for bowel obstructions in the general surgery patient. Obviously, physical exam, labs and vitals can push towards earlier operative management, but for the stable patient, CT scan might be really helpful to evaluate for transition points. And then for kind of the more distant post-operative patient or anyone who just has adhesive small bowel obstructions, sometimes use of gastrograph and small bowel follow-throughs might be helpful diagnostically and therapeutically. As far as intussusceptions go, this can occur at the jejunal anastomosis with the involved bowel being at risk of ischemia. Management of this, specifically for patients with obstruction and evidence of an intussusception is typically operative if the bowel is not able to be reduced, or if it's a very large dilated JJ anastomosis, consideration could be given to resection and reanastomosis. But non-revisional management can also be considered for higher risk patients with just reduction only, or imbrication, plication, or jejunopexy. So in the previously mentioned patient, bleeding was also a predisposing factor to her bowel obstruction. Again, it's kind of related to what in the anatomy has changed, which is basically tells you where the bleeding could occur. So basically anywhere there's a staple line, except in these cases, bleeding can also be intraluminal in addition to intraperitoneal, and both obviously present differently. As far as overall bleeding complications, this is a wide range of incidents, 0 to 20%, depending on the series. Again, risk factors include coagulopathy, liver disease, hypertension, super obesity. And then as far as operatively, for circular staple anastomosis specifically, this has been also implicated with the higher risk of bleeding. And some of the thoughts related to that is the inability to look at the staple line at the time of anastomosis as compared to a linear stapled or hand-sewn anastomosis, where you're able to visualize the staple line, control it with suture manually. And for if you're doing a two-layered closure, the thought for that is also it's more hemostatic due to more tissue approximation. As far as other maneuvers that you can perform to reduce risk of bleeding, some thought, but data conflicting, being staple line reinforcement, fibrin sealants, and also just appropriate staple height choice for the appropriate tissue.
Dr. Hassan has a question.
Yes.
Sorry to keep on torturing you with my questions, but so again, not a bariatric surgeon, but what's a jejunopexy? You've mentioned that as a thing of doing for obstruction. And then the second thing about the anastomosis, I mean, even when you were talking about circular anastomosis having a higher incidence of strictures, has it ever been shown that one anastomosis hand-sewn versus stapled is better than the other one overall? I mean, every study that we've been done has always been some kind of bias built in it. So just in general, my understanding is that they're all about the same with some variation, but I'm just curious to what your thoughts were.
Yeah, as far as jejunopexy, correct me if I'm wrong, either Dr. Altieri or Dr. Podkameni or anybody, but I think for that, you're actually pexying part of the jejunum to reduce the risk of reintussusception. As far as the other methods, plication or imbrication, I think that's also used to make the JJ anastomosis, I guess, more tight, to be less likely to cause repeat intussusception. That's my understanding of it.
Does it work?
Dr. Pod, I think you're muted. I think there's still a risk of recurrence for any of those maneuvers.
So I think the jejunopexy and this kind of maneuver you would use just as the last resource on a patient that it's like really in dire straits in the operating room, because what we end up seeing is a recurrence of that intussusception. I think one of the best approaches is really to end up redoing that anastomosis. Unfortunately, you're going to change one anastomosis to a two anastomosis where you have bowel resection involved into that. The alternative to that will be a middle ground, is to do a Braun derivation. So this way, having a Braun, usually it will fulfill that role of the PAXI, plus the fact that you have more of a fixed bowel now, trying to avoid that to intussuscept as well. And you are asking about the stapler, and the bariatric literature, at least on the GastroJudge, shows a higher incidence of stenosis on circular staplers versus linear staplers versus hand-sewn anastomosis, in that order. So at least in the bariatric literature, when you look at gastrojejunal anastomosis, there is a crescendo from incidence of stenosis between circular, linear, and hand-sewn anastomosis.
Why do you think that is? I mean, is it just the technical thing?
I think it could be involvement of how the blood supply is affected by one versus the other. It's speculation. To be honest with you, I don't know. But if I have to guess, it will be how the blood supply happened to reach the anastomotic area, where with the circular stapler, you are sort of like taking a circular hole around it, not allowing some of that blood supply to get it. It's speculation. I don't know.
I agree with that. And Imran, I had a partner who constantly did that 21 circular stapler, and there were so many strictures after that I had to dilate almost like every other patient. So I think the size matters a lot as well. I think that like maybe the 25 versus the 21. I personally do a linear, then hand-sewn to close the enterotomy, and I knock on wood, I haven't had any issues. Again.
And we do the same. Either we do a full hand-sewn or a linear stapler mix with a hand-sewn for the closure. And one thing that I think it's important also to remind all of you is the fact that using a circular stapler between a 21 and 25, and you have a higher incidence of stenosis with a 21, is remembering how bariatric surgery works. 20, 30 years ago, we did think that doing a very super tight anastomosis in a tiny, small pouch was the answer to everything. And we know this is not true from the fact that this is indeed a metabolic change that happens. So it doesn't make that much of a difference by the end of the day if it's going to be a 25 or 21 when it comes to weight loss. But it does make a difference in terms of complications when it comes to stenosis, for instance.
Thanks.
Do you think anything to do with like the scarring mechanism between open and laparoscopic? Because the 21 really came from the open era, and they cited less problems. When we went to laparoscopy, most people that did a circular stapler went with the 21 as well, and they found way more stenosis. Do you think maybe it's like a scar tissue from the fact that the procedure was done open that maybe held it apart, and then when we did laparoscopic, there was lack of kind of adhesion and things kind of scarred down? I don't know. Does anyone think?
I don't have any opinion on that. I'm sorry.
I was just wondering because I meant
I think it's something we can keep on speculating, and we just don't have a good answer.
Yes, exactly.
I don't buy the ischemia, by the way, just to create more speculation, because the stomach is so vascular. I mean, why? That's the one thing that's hard to kill the stomach, right?
It is very hard.
And then the colorectal, that's all we do is circular anastomosis. I mean, 28, I know they're slightly bigger, so which is much more susceptible to ischemia. So again, I guess more questions than answers, but again, good discussion.
You also change the response where you have 3 layers of muscular layer in the stomach, and you have only 2 layers in the colon. So I don't know if that actually plays a role when it heals up. So to be honest with you, like I said, I think we can speculate the whole day, and we're not going to find an answer.
Can I ask
Yeah,
one more question?
yeah.
Sorry. Felipe from Miami Cancer Institute, doing the fellowship with Dr. Asman. When you do the anastomosis with a stapler, do you close the gap in a single layer or in 2 layers?
Dr. Reyes.
Yeah, so for us, in terms of closing, like I guess the common gastroenterotomy, we do that essentially in 2 layers, kind of a running vicryl suture from the, I guess, upper apex all the way down and then again back up. So basically in 2 layers.
2 layers with a single suture?
No, actually 2 sutures.
2 sutures, okay. Does anybody do a single layer or?
In fellowship, I used to do a single layer, but then I switched. I just wanted to go back to Dr. Hassan's, and then I'll switch back to here. But when they, Imran, when some people actually, when they do the circular stapler, they also oversaw very similar to us. So they'll do the circular stapler, and then they'll imbricate the GJ. So I think that further strictures, it leads to strictures. Again, it's just an observation. So
not to stir things up, but when I do my colorectal anastomosis, I always oversaw it also. So again, I don't know if that makes a difference. I sleep better though.
Yeah.
Same here. So very similar. So that's what I was gonna say. Like in fellowship, we did a single layer, and now I switched to double layer, and I've never had a leak, and I sleep better. So
Yeah, we're switching now. So we always did when we did like subtotal gastrectomies, we always did 2 layers. Now we're switching to single layer with 3O Stratafix. So I think.
Conclusion, many ways of skinning a cat.
yeah, you can do endostitch. We can do polysorb and Surgidac, like, one layer and then the other. Different people, different things. Again,
Yeah.
you can do this many ways.
And the biliopancreatic limb, you always leave it to the side where the stapler closure is, right? I would assume everybody does that, right?
I'm sorry, what do you mean by that?
So when you do the gastrojejunostomy, the biliopancreatic, oh no, but you do Roux-en-Y. You don't do Bureau 2, right? No, it's not an appropriate question, sorry.
So if you refer to one anastomosis gastric bypass, yes, you're right. So this way you're not doing an anti-peristaltic loop.
Mm-hmm. Okay.
All right. So just moving on, management for bleeding, essentially the same as any other bleeding. Correction of coagulopathy, resuscitation if blood is needed, and then operative or endoscopic or even angiographic intervention, depending on the location of bleeding. As far as staple height and appropriate staple load choice, this can vary, of course, depends on tissue thickness. So instead of kind of broadly applying the same color or same height, I should say, for either stomach or small bowel, there should just be more attention paid to the actual height of the staple. For example, in revisional cases where you might be anticipating thicker tissue, you might choose the next size up for staple load. That's also like a very individual consideration. But overall, it's just a balance of obtaining adequate tissue approximation without ischemia and balancing that with adequate compression for hemostasis.
Dr. Reyes, there's a couple of questions in the chat, I think.
Okay.
One of which is general surgeon here. Do we really want to treat workup high-grade small bowel obstruction in post-bariatric patient like adhesive-related SBO and non-bariatric patient, given the catastrophic possibility of an internal hernia from Peterson or mesenteric defect-related hernias? Is an early operation in this patient, in this post-bariatric SBO patients preferable?
Sorry, I'm trying to digest the question.
I
think this.
McCullough, if you wanted to ask your question as well, that would be great.
Sure. I'm just asking, why would we do we really want to push for a gastrographin challenge in a post-bariatric patient as opposed to adhesive? I mean, a non-bariatric patient, there's a significant chance of adhesive-related disease. A bariatric patient, it's taken us years to teach our general surgeons not to sit on these bariatric patient SBOs. And I mean, I think, is that now the way the bariatric community is pushing to use gastrographin challenges?
No, I can tell you right now that my practice is not the same as a non-bariatric patient. So I'll never put an NG tube NPO and like kind of watch them. I am more, you know, I guess proactive in terms of taking them to the operating room and just evaluating, because and we can talk about how we do like well, Dr. Reyes, how do you usually do, like if you're in concern for an internal hernia, for example, how would you do your ports, and how would you what is your operative approach for an internal hernia?
Right. Yeah. So for an internal hernia, I'd plan to stand on the left side of the patient because I'm going to be running the bowel from the ileocecal valve from a distal to proximal direction to both identify as well as reduce the internal hernia. That's kind of how I would plan for it. So ports on the left side, but kind of triangulating to the ileocecal valve.
Anybody else has any other approaches? Or
I think kind of like an L works pretty good, you know, mostly on the left, but across as well. So there's like, you can kind of reach in to over top and at the bottom. Also, I think it nuanced, but it also depends on whether the patient had their operation opened or not. Right. I mean, I think someone who had laparoscopic surgery is really at much higher risk for internal hernia. Whereas if you were like a patient, you know, knocked out Capella 20 years ago, chances are you had more likely to get an adhesive obstruction than an internal hernia. So I think, like I said, it would best would be if there is bariatrics around, you know, should go to them. But also, I think there's nuance in the type of operation they had as well, right? Whether it was open or laparoscopic.
And so the way that I do my internal hernias in terms of, I actually usually start again on, it's very similar to you on the left. I'll do three ports, and I'll start running from the ileocecal valve. Most of the time they actually reduces, but at one point it becomes a challenge to just stay on the left and keep on running with the bowel backwards. So I actually have the assistant take over and run it from the other side, especially when we go towards the JJ. I'll look for the mesenteric defects and then just kind of in a systematic matter, like the JJ first and then Peterson's. One more question that I have for you: if you are like, if you have the operative report and you have somebody who's actually had a closed, you know, like the operative report, you read that both defects were closed, would that change your, I guess, algorithm going to the operating room, or would it put you at ease?
I don't think it would necessarily change my algorithm with going to the operating room. Of course, if I'm suspicious of an internal hernia, I would opt for earlier operative management for that patient. As far as whether they were documented as closed, I don't think it really matters. But I guess if they were a recent post-op patient and they mentioned that they had closed it, I guess I'd be concerned about internal hernia even more for those patients with bowel incarceration within those hernias.
So I've had a few times where actually we'll go in there and I can see that there is sutures, and then just like it's kind of unraveled. So it's just because somebody states that they closed it, it's honestly like fat to fat. Sometimes it's closed, sometimes it doesn't. So that just because of that finding, that will not change anything. And there's also another question: what if no bariatrics available? We've been pushing our residents and staff to early diagnostic laparoscopy, laparotomy for small bowel obstruction in these patients. And I agree.
Yeah, I think that's the right thing to do.
Do you guys close, like whoever does bariatric surgery, do you close your defects? I'm just curious.
I'll answer. I don't close. I don't close. I've read all the randomized control trials, you know, the largest ones. and I still don't close my defects. We monitor our incidents, and well, from even you can say, well, what if the patient had an internal hernia is in another hospital? That's why we call them, we email them, and we follow up with them. And what we see most of the times is that the defect itself, when we have to go back, the defect sealed itself off for one reason or another. We end up going back. It seals itself. And like you said, sometimes what I see is the opposite. When you close the defects, a tiny little hole that was left or the suture unravel, you see a much acute internal hernia. Having said that, I'm not saying it's wrong to close a defect. If you're going to follow randomized control trials, you're going to close all your defects.
I closed the jejunosity defect. I think I can identify that defect really well and close it well. I don't close Peterson since I've been doing anticholic. When I use retrocolic, I used to close all the defects because they were all easy to see. So I think the problem with the Peterson's defect is that there's actually two spaces, kind of, right? One above the colon, one below the colon. And I don't know if you can necessarily close that defect well. So I think that's a problem. Just partially closing it is worse than not closing. But I think the JJ defect I could see very well, and so I closed that. And I think like the debate's obviously still there because Cleveland Clinic and people at Emory, they don't close any defects either. So yeah, go ahead.
Yeah, no, since I was going to mention the Cleveland Clinic because that's where I did my training, and we used not to close, and I just continue not closing my defects. It works for us. It doesn't mean everyone needs to do the exact same things. And if you look at randomized controlled trials, like I said, everyone closes. But one thing that people don't ask is how you open your mesentery when you're doing anastomosis. And some people just, when they are doing their resection or their section on the jejunum, they end up actually stapling the mesentery as well, making a very large defect. And different than that, we make a very small window near the edge of the bowel. So because of that, our defect is not as large, and maybe that's why it seals itself so frequently. So this is something that it's not explored when we talk about closing all the defects.
I love this discussion, but Dr. Reyes, you want to just bring us home? We're got one more minute to wrap everything up.
Yeah, so the most complicated case, but no questions about it. 45-year-old female, morbid obesity, essentially transferred to us following a leak after a single anastomosis due to a bypass or SIPS. So this patient had to be managed with multiple modalities, including endoscopic therapy with multiple attempts at endoscopic clipping, endovac and stents. But just to kind of illustrate the anastomotic leak is very difficult to manage in some cases. Fortunately, low incidence, but high morbidity and mortality. Risk factors are very similar to the other complications, pathogenesis being tissue breakdown, a little bit of ischemia, and sometimes in some cases distal anastomosis contributing to intraluminal pressure and leak. So as far as intraoperative concerns for this case, staple line compromise, so importance of adequate staple formation, appropriate height choice, appropriate tension while stapling. And as far as risk factor or risk reduction intra-op, we talk about leak tests, which can identify staple line disruptions intra-op, but haven't been shown to identify areas of leak post-operatively. Management of fistulas, acutely control of contamination, IV hydration, and then later on nutrition, but acutely can be managed operatively, but as far as delayed or chronic leaks, this is more so non-operative management, usually TPN, but a combination of endoscopic therapies, like I mentioned. All right. So as far as just conclusion, so the important first step in management for patients with anastomotic complications is just the understanding of their current anatomy. Pathogenesis for these complications is multifactorial. Tobacco and NSAID use being a big modifiable risk factor, but with also some technical considerations as well. It's frustrating for everybody involved. Avoidance of large revisional procedures in the setting of inflammation due to the risk of breakdown. But as far as leaks go, it's multimodal management for that. All right, and that's all I got. Thank you, everybody.
Thank you. Great job, Dr. Reyes. Dr. Artillery, thank you very much for joining us. You want to just give us our last minute comments, and then I look forward to seeing everyone next month. We're talking about quality outcomes in hernia care.
Great. Thank you so much, Dr. Benzi. Dr. Reyes, great job.
Thank you.
Have a great night, everyone.
Thank you.
Great night.